Hey guys, so this is the review on hiatal hernias. I'm getting tired. Okay, so they are also called diaphragmatic hernias, and this is where the stomach protrudes through the esophageal hiatus of the diaphragm. It was right in the last video. It's the diaphragm. They are going to have symptoms similar to GERD if they have symptoms, but most of them will be asymptomatic according to our book. And this is chapter 54. Um, okay, so there's two different types of two different types of hiatal hernias. So the first one is a sliding hernia, which is the most common, and that's just where the diaphragm, uh, the muscles weakened, so they end up with esophageal reflux. And the other type is the paraesophageal hernia. It's also called a rolling hernia, which is a anatomic defect. That one's where the fundus rolls through the esophageal hiatus. So in the photograph in our book is on page 1092, and the paraesophageal one is where the stomach is. This is gonna look bad. It's like protruding through this is your diaphragm, and this is the stomach. It's like protruding through the diaphragm. Whereas with the sliding one, the stomach's just kind of sliding up and down in there. So yeah, look at the photo in your book. So, in rare cases, the stomach inverts into the chest with the paraesophageal hiatal hernia. They are at risk. Sorry, my battery is low on my baby monitor. So, I have to text my husband. Okay. So, all right. The risk for those patients, in particular the paraesophageal hernia patients, is that they are at risk for volvulus, which is the twisting. Remember, she talked about the twisting of the GI structure. They're also at risk for obstruction and strangulation. So you definitely don't want that. They also have can possibly have an iron deficiency anemia. That is from venous obstruction in the where the diaphragm is obstructing the stomach. So we want to assess for heartburn, regurgitation, pain dysphagia, belching, symptoms similar to asthma, especially at night. And then with the rolling hiatal hernia, they're going to have a feeling of fullness after eating, and also breathlessness and chest pain. So battery's low. Thank you. So as far as diagnostics, we are going to do a barium swallow with fluoroscopy with these patients, and they could also do an EGD. There is a chart I have circled in the book. It is chart 54-4, and it is going to tells us the difference between the symptoms of the sliding hiatal hernia and the paraesophageal hernia. So with the sliding one, just think of GERD. So, heartburn, regurgitation, chest pain, dysphagia, bulging. With the paraesophageal hernia, they're going to feel full because their stomach's protruding through. There's less room in there for the food that they actually do eat. And they're going to be breathless because that stomach that's protruding through the diaphragm is going to be bearing up against the lungs. So just a general feeling of suffocation. Chest pain that mimics angina, and then worsening manifestations in a recumbent position. So if they're laying supine, of course, this is going to aggravate things. Let's see. There is also a yellow box on page 1093 with our teaching, which is a really great topic for a SATA question. So when we're teaching patients with hiatal hernias, we want to make sure that they know a lot of the same things that we are teaching our GERD patients, actually. So they should avoid eating late at night, and foods associated with reflux. Again, those foods that we mentioned in the last video, that good stuff, tomatoes, chocolate, peppermint, caffeine, yeah, we went over a whole list of them. And then they should also exercise regularly and reduce their body weight if they're overweight. And again, that's going to increase their intra-abdominal pressure. They can also elevate their bed the same way we do with our GERD patients, 6 inches with the wood blocks. And then they need to remain upright for a few hours after they eat, give that food time to settle. They also need to avoid straining. So if they're picking up heavy objects, not a good idea. Also, if they're constipated, we don't want them straining. And then excessive vigorous exercise. So they probably shouldn't be doing HIIT training or P90X. They also need to avoid tight clothes because that will make things worse. When patients have sliding hiatal hernias, you're really wanting to do diet modification and lifestyle modifications. We generally aren't going to get surgical with those guys. The rolling or paraesophageal hernias, the go-to for that is going to be surgery, just because there's really not much else we can do in that aspect. For pre-op, the surgeon is going to want them to lose weight if they are overweight, and then also they need to quit smoking. So if they're a smoker. For the surgical options, they have several options. One of them is the lower esophageal sphincter fundoplication, and that is the one where the surgeon wraps a portion of the stomach fundus around the distal esophagus to anchor it and reinforce the lower esophageal sphincter. And we watched a video on that. I think she posted the links to those. Now, one of the other ones is the laparoscopic Nissen fundoplication, the LNF. That is better because it's laparoscopic, so it has less complications and a faster healing time. So that one, they can go transthoracic. So we want to teach the patient about chest tubes because it's likely they're going to have them. Also teach our patient about nasogastric tubes. The NG tube is probably going to be in for several days. One, because we know from lab that they really need to decompress the stomach. Also because they're going to be on clear liquids, basically to reestablish or stimulate peristalsis. They're going to gradually increase to a regular diet. So they will also need to be taught how to use we need to teach them how to use the incentive spirometer. And then the high incision with that transthoracic surgery makes it really painful when they breathe. So go ahead and teach them that before surgery so that they know that's going to be a pretty painful thing to go through, but that we will give them analgesics and monitor their pain pretty continuously. So another option they have is the paraesophageal repair, which is laparoscopic. Can be done laparoscopically or open but they prefer to do it laparoscopically, but in some situations they have to do an open one. With a laparoscopic option, it's going to be 1/2 inch incisions made in the abdomen. The hernia is closed and reinforced with a mesh. So they are at risk with all of these procedures, for bleeding and infection. And then I have chart 54-5 circled, and chart 54-6 circled. So those are going to be the postoperative instructions, and then also assessment of postoperative complications. That is on page 1094. So with the postoperative instructions, this is also a great STATA question for our exam. So, they need to be on soft food for a week. They need to take their anti-reflux meds for an entire month. Also, no driving for at least a week. And if they're still on opioids after that week, of course, they shouldn't be driving. They need to walk every day. No heavy lifting. And also, this is really important. So if a patient has stair strips, little sticky, usually sticky long bandages, those are going to go underneath their post-op gauze, and they do not need to pull those off. I've had a lot of patients do that, and I don't know what the deal is with that, but they need to just let them fall off naturally, or they can take them off very, very gingerly after they have healed completely. But I don't know how many patients we've had tear off their stair strips, and then they end up, bleeding really bad and having to go to the ER. They have to fix it. It's a mess. So yeah, teach them about the stair strips. Don't take them off. In our book, it says 10 days afterwards. And then the small dressing, the gauze, post-surgical gauze, they can take off after 2 days. They need to wash their incisions with soap and water. Again, leave the stair strips on. Just put the soap and water over them. Keep it simple. And then they need to report any redness or drainage to the surgeon. And then also, if they have a fever over 101, nausea, vomiting, uncontrolled bloating, or pain. And then if they're over 65, then they need to report any fever over 100. We want to really watch these guys for infection. So infection and bleeding. And then their post-op appointment with their surgeon should be scheduled 3 to 4 weeks later. Sooner if they have complications. But we need to really collaborate with the respiratory therapist for post-op care as well. And then in class we discussed this. The initial NG drainage should look dark brown with old blood, but within 8 hours after surgery, it should be yellowish green. So if it's red, you need to tell the surgeon immediately. If it's 8 hours out, it shouldn't be that color. Also, we need to check their NG tube placement every 4 to 8 hours. This is really important. We're checking for placement and patency. Because if that NG tube has to be reinserted, then that patient is at very high risk for perforation. And we don't want to put any patient through that if it's unnecessary. Also, the NG tube, again, is for decompression, which we talked about in the lab, and that prevents the patient from having vomiting. If they vomit, then it's decompressed, and we can avoid a lot of issues there. Also, we need to do frequent oral hygiene. The patient needs to avoid caffeine, carbonated beverages, and alcohol. During the healing process, it will be severely restricted or most likely just eliminated altogether. So we need to also supervise their feeding because of the dysphagia. Really, really common. And if they are continuing to have dysphagia for a long period of time, then that probably means that the fundoplication is too tight. And in that situation, they'll need a dilation procedures to loosen things up. So another complication is the gas bloat syndrome, where they can't voluntarily belch. That's usually temporary, but can last longer. And then for teaching, we want them to restrict their activity for 3 to 6 weeks. If it's laparoscopic, now that's with an open procedure. If it's laparoscopic, then we just want them to restrict their activity for a few days to a week. They have a much faster healing time, and of course, usually the surgeon will give them specific lifting, pushing, or pulling restrictions. And then in the long term, after these procedures, they should use bulk laxatives or stool softeners, because we really don't want them straining until their healing is complete. And then they need to just notify us if they have any redness, swelling, tenderness, discharge, or fever from, anything near their incision sites. But also, if they have cold and flu symptoms, they need to let us know right away, because with any esophageal surgery, you're going to have respiratory risk of respiratory complications. So they should avoid people who are sick with any kind of respiratory illness. And then they need to call us and let us know. And also, if they have reflux symptoms, they can let the PCP know. And then I think the last thing was just you probably need to do a consult with a registered dietitian. They really need to make sure their diet's on point after this. They really need to avoid foods that would build up gas, and foods that, are just not going to be helpful, like, alcohol. I think that's it for hiatal hernias. So again, maybe we can all watch those videos that we watched in class, and then post any questions. And hopefully that was everything. Really think of the hiatal hernias and GERD as being super similar. A lot of these diseases have some overlap, but again, remember, basics. This is MedSurg 1, so I think that was a pretty good little review. So let me know if there's anything else you guys need or want, and I will move right along to esophageal tumors. All right, night, guys.